Good morning, everyone. Welcome to the New Haven Alumni Chapter of Delta Sigma Theta Sorority Incorporated's 2021 Health Symposium entitled Empowering Women Through Their Healthcare Journey. My name is Katrina Rice. I'm the first Vice President of Program Planning and Development of the New Haven Alumni Chapter of Delta Sigma Theta Sorority Incorporated. We are delighted you chose to be with us today. We want you to have a wonderful experience. Please be assured your safety as well as your enjoyment of this event are of our utmost concern. Please take a moment, look around, and identify two exits. Whether in a virtual setting at your home or physically in some formal venue, we must always be Delta ready. So please identify two exits now in your current location in the event, if necessary, to evacuate quickly and orderly in case of the need for our emergency evacuation. Before we proceed, I would like to make everyone aware that all participants on the call will be muted, also known as listen-only mode. Upon logging into today's workshop, you were provided with the option to choose your audio mode. Please note, if you are dialing in just by phone, you must press *9 to raise your hand to be unmuted by the host. In addition, if you have a question during the meeting, please click the white arrow in the red box in the upper right-hand corner of your screen. This will open your window, which will allow you to type your questions in the chat. We encourage you to pose your technology questions in the chat as they will be directed to the technology support. Please understand that questions directly pertaining to technology will be answered immediately. You can either type your question or you may also click on the hand icon so that you can be acknowledged and taken off of mute to pose your question. Also, during this COVID-19 pandemic, please remember to wear your mask, wash your hands, and always walk and stand 6 feet away from others. Please enjoy the event and continue to be safe. As a reminder, this meeting is being recorded. Welcome. Now I would like to hand over to our chapter president, Sarah Paula Irving, to give us a welcome.
Thank you, Katrina, and good morning, everyone. Thank you for joining us on this lovely Saturday morning, our first Saturday in June. So we are making our way into summer. So my name is Paula Irvin. I'm the president of the New Haven Alumni Chapter of Delta Sigma Theta Sorority Incorporated. Delta Sigma Theta is a private not-for-profit organization founded on January 13, 1913, whose purpose is to provide assistance and support through established programs and local communities throughout the world. So this is our annual health symposium, which we've had to shift to a virtual platform. We're so excited to still have such wonderful discussion and panelists today to discuss empowering women through their healthcare journey. As we go through life, there's many things that come about. So we want you to take this time to really just soak in all the information, ask any questions you may have, and also just, feel free to use this space as one that we can just come together and just have a conversation. So again, thank you for joining us on this Saturday. I'm going to turn it back over to Katrina and we'll get the program started. I'm so excited for the conversation. So I'm just here to just soak it all in. Good morning.
Good morning. So thank you, Madam President. I would like to introduce Yvette Wooten, who is our chairperson for the 2021 Health Symposium. Yvette, for her to do a welcome and her introductions of our wonderful guest speakers.
Good morning, everyone, and welcome. We're excited for you to be here with us, sharing this time to learn more about women's health. The two panelists that we have such wonderful knowledge to share, and I'm gonna get out of the way so that they can get started. And I'm gonna start with Jessica Westbrook. I'm gonna read her bio, give you a little bit of information about her before her presentation starts. But please, as you're listening, use the chat to write down any questions, and they will be shared during the presentation. So welcome, everyone, and we are so excited to have you with us. Jessica Westbrook is a New Haven native who is passionate about uplifting and supporting her community. By providing birth services, she is able to advocate and provide a safe space for new families. She is a mother of 3 who has gained a tremendous amount of hands-on knowledge and experience with pregnancy and postpartum needs of every mother. She plans to expand her services to other aspiring doulas in the community by offering scholarships for those who are interested in birth and postpartum doula certification. Furthermore, she is working to decrease mortality among women of color during pregnancy and birth by offering her services to underserved communities in Connecticut. Jessica is the founder of the Lotus Doula Group in New Haven, Connecticut, a childbirth international certified birth postpartum doula and placenta encapsulation specialist. So please welcome Jessica as she comes to share her most valuable information with us.
Thank you so much. Can I just hire you to do that for any kind of program that I'm on? You did that so well this morning. Thank you all so much for joining us. I'm always very grateful to be able to share any sort of expertise or information that I can to women in our community, to let people know that I am here and I am a resource. I am one of only 3 doulas of color who are certified in the state. So we don't have very many options. However, I love to be able to share this information with women of color in our community. And we can start our presentation. Thank you so much. The Lotus Doula Group's mission statement is to provide resources, advocacy, and support for mothers of color through birth and postpartum. Next slide. The country's infant mortality rate is at 5.8 currently, which is really, really high. Black women are 3 times more likely to die in childbirth than white women. In Connecticut, the infant mortality rate for African-American babies is 4.5 per every 1,000 live births, with Mississippi having the highest rate at 9 per every 1,000 births. Next slide. What is a doula? Sorry, I can just, yes, thank you. A doula is a trained non-medical professional who supports an individual through significant health-related experiences, but not limited to pregnancy, labor, childbirth, and postpartum. Next slide. In 2002, the Cochrane database review of 15,288 women found that women who had continuous labor support from a doula experienced a 9% decrease in pain relief medications, a 31% decrease in the use of Pitocin, a 28% decrease in the risk of cesarean section, 14% decrease in newborns being admitted to the nursery for care. Next slide. When is the best time to hire a doula? That is a question that I often get from people who I meet for the first time. I've had clients who come and call me a week before their scheduled due date. And I have clients who call me in their first trimester, eagerly waiting and excited to book doula services because they've heard so many good things about it. It's never too early to hire a doula, so it's best to start the interview process as early as possible. The ideal time to hire one is 5 to 6 months before your estimated due date, but it's never too late in your pregnancy to consider hiring a doula. Most doulas book early and quickly and have repeat birthing families. However, in Connecticut, we do have a lot of doulas that do this on a volunteer basis through Yale. So mothers have more access to doulas than a lot of other states. Next slide. Can I benefit from a birth doula if I'm considering pain medication? The answer is absolutely yes. A doula is beneficial assisting with any and all births, including a medicated birth. Some expectant parents prefer no medications. Others want to begin with no medications and reserve the right to change that decision. During services, a lot of doulas offer birth plans, which become an outline of what your plan is for the day that you decide to give birth. that we can go over with nurses and doctors and midwives the day that you decide to go into labor, or that baby rather decides to go into labor. The choice to use pain medication or not is completely up to you. Doulas support any of your decisions as long as you are healthy. Next slide. What is a postpartum doula? A postpartum doula provides non-medical support in these important days and weeks following delivery. This support is emotional and physical, as well as informational. And while the doula does help with infant care, her primary focus during this time is the mother. He or she might be able to provide families with information and support infant feeding, emotional and physical recovery from childbirth, infant soothing, and coping skills for new parents. And they might also help with light housework, fix a meal, and help incorporate an older child into this new experience. Next slide. Thank you. Next slide. Why is it beneficial to have a doula? You know, having a doula is one of the biggest and best investments that you can make in yourself when you are expecting. As a new mother or a new father, a doula is really, really beneficial to a family due to the attention to physical comfort through techniques such as touch and massage, emotional reassurance, and comfort and encouragement, information about what's happening during labor and postpartum period, including explanation of procedures, help with facilitating communication between yourself and the hospital staff, and most importantly, giving you advocacy. Every one of my births is different, but one thing that customers and clients do say that they enjoy the most is the advocacy portion that comes with having a hospital birth, so that they have the information that's needed and they know what their options and choices are. Next slide. This is just an overview of the benefits. Next slide. What are the differences between a midwife and a doula? A doula is primarily focused on the emotional and mental health of their client and family. We usually join the client at home for early labor and stay throughout labor and delivery. Doulas are in the delivery room with the client the majority of the time, whether that is through a natural, medicated, or a C-section. Doulas aim to ensure your voice is heard and to help you feel empowered and in control of your birth. Midwives' roles are to focus on the medical health of the patient and baby, and they collect data and assessment risks and advise responses. They begin active care when the patient arrives at the birth location. So their care does not start until your home birth or your hospital birth is actually in active labor. They are usually out of the room attending to required medical duties most of the time, so you will not get one-on-one attention. And they aim to ensure that you and baby are safe and healthy, and they address any complications. Next slide. If I am under midwifery care, do I still need a doula? Next slide. The answer is absolutely yes. Whether your decision is to be under the care of a midwife, an obstetrician, or a general practitioner, a plan to give birth in a hospital setting or a birth center or at home, a doula is an essential part of your birth team. We offer continuous support regardless of your chosen environment, healthcare provider, or birth desires. Next slide. If I have a C-section or a scheduled C-section, will I still get support from my doula? Yes. Even in a surgical setting, a doula is there to explain what is happening and guide you through the procedure, and even create a personalized birth plan if this is a planned C-section. Your doula will also be there during recovery to help with the first breastfeeding and bonding. There is a possibility at times that your doula may be able to accompany you in the operating room, and unless it's a extreme emergency and you have to get general anesthesia. Next slide. What is placenta encapsulation? Placentophagy is when a mother consumes her placenta by eating the placenta raw, cooked, or in capsule form. Currently, I am the only person of color that is certified to encapsulate placenta in the state. I decided to study this after doing it myself, and then realizing that women of color have no idea that this is a resource that we can use. And I found that a lot of women of color weren't as trusting to get this because they didn't have someone that could relate to them culturally. Next slide. Thank you. Next slide. What are the benefits of consuming your placenta? Postpartum, most mothers see an improved mood, increased energy, decrease in fatigue, alleviated postpartum bleeding, enhanced uterine involution, which means that your uterus will return to its pre-pregnancy size faster, accelerated weight loss, improved lactation, it replenishes and regulates hormone levels, the prevention and relief of headaches, and the only negative effects are that there's an unpleasant taste or smell, depending on how you are consuming it. Next slide. The placenta methods of preparation are the gentle method, in which the placenta is lightly steamed with herbs such as lemon, peppers, ginger, frankincense, and myrrh. The raw method, the placenta is not steamed prior to dehydrating it. Encapsulation, placenta is steamed and dehydrated and then added to capsules for consumption. Raw consumption is exactly what it sounds like. It's primarily used as a remedy for blood loss and can be consumed directly from the freezer for up to 6 months. Tinctures are raw, untreated placenta that is extracted into alcohol for 6 weeks, and it can be used indefinitely. So if you suffer from different thyroids or menses pain, you can pass this tincture on to your own daughter and her daughter as well. Salves, placenta is dehydrated into a powder and infused into a cream. This is really helpful for women who have to have a C-section. They have dermatitis. This is great for diaper rash and cracked nipples for nursing. Next slide. Placenta severance. Surgical severance is the hospital surgically removes the umbilical cord from the baby, which is what most people opt to do. Cord burning is a sacred ritual where the cord is burned by fire. I've had mothers who have their other children take part in that, and they all choose a candle and they burn it that way. And then a lotus birth this involves leaving the baby umbilical cord attached for the extended period of time while the umbilical cord and placenta dry out. Next slide. How does my placenta get encapsulated? Once you give birth, a specialist will come to the hospital and they would pick up your placenta for you. It is then cleaned and sanitized. Once it's sanitized, you steam it in a steamer, and then it is sliced into small pieces and dehydrated. Nothing else is added to your placenta. It is 100% yours. It then goes into a blender and it becomes a powder. And then in capsule form, you would take it the first 3 weeks for maybe 3 pills a day. And then the next 2 weeks, 2 pills a day, and then so on and so forth. Each placenta usually renders between 150 and 200 capsules that you can consume during that period. Next slide. How much does it cost to hire a doula? In Connecticut, prices range from $800 to $2,500, excuse me. So it definitely depends on your location. Currently, doulas are not covered through Medicaid insurance, but for CTSB1, we may be seeing progress in that by the end of this year. Most doulas can accept payments through HSA and FSA accounts. Aetna, Blue Cross Blue Shield, Harvard Pilgrim, and Connecticut will cover postpartum services. And my most favorite option is to consider baby shower gifts or group contributions for a mom to be. So you can add this to your registry, and some people contribute to postpartum visits or for you to have a baby, a birth doula during your labor and delivery. Next slide. This is the current legislative effort, CTSB1. It is an act of equalizing comprehensive access to mental, behavioral, and physical health care. This is what doulas are fighting for, to be able to be reimbursed for doula services through Husky so that we can continue to assist with underserved communities. Next slide. And that's all I have for you today. I hope that the information that I shared was helpful. Feel free to reach out to me or pop a question in the chat. I'm happy to answer. Thank you so much.
Jessica, we do have a few questions in the chat.
Sure.
So the first is, how would you describe your doula style?
Oh, that's a really good question, whoever asked that. My doula style is always remaining flexible. I don't treat every family the same. Obviously, professionalism will always remain the same. However, my need is contingent on what your need is. So I would say my style is very calm. When I see my client having a stressful kind of situation, I will step in and mitigate and, ask, is it okay for me to speak to your provider on your behalf about some of the concerns that you have? And then we can discuss together what your options are and what you want to do. So always to remain supportive. I've heard that I just have a really calm style. I don't know how. Maybe it's because I have 3 children. My patience is a virtue at this point, but that's what I would describe my style as: flexible and supportive.
The next question is, how do you most often support women in labor? And another question that I was typing in the chat, which sort of goes along with this, how do you incorporate husbands or partners?
Oh yeah, they're just as important. So that's a really great question as well. When a mother comes to me for doula services, I do ask who her support system is. And if that is a partner, I do offer and extend that they join in on our virtual meetings or in-person meetings. I also share my information with them. There are a lot of times, especially during COVID, that I had to basically train the partner to become the doula because I couldn't be there physically. Partners are just as important as moms because they're not actually laboring. We have a thing that we're doing. The baby is coming out of us. But so they oftentimes feel a little bit lost. But if I'm doing a massage technique, I may include their partner in the actual facilitation of that. If mom is needing to have her garments changed, I may mention to him, or her, this is what we need to do. Can you please contact the nurse so that we can include you in that? Sometimes it's just holding one hand and one leg and then the other as well. So definitely, I hope that I answered one part of that question, was that that's how I include the partner. But what was the other part of it?
How do you most often support women in labor?
Yeah. So just getting back in the hospitals, sometimes it depends if they are getting an epidural, sometimes my positioning has to be different. I'm not afraid to kick off my shoes and get in bed with mom and turn her over on one side and, have her on all fours. So definitely positioning is something that I really, really give an emphasis on prenatally, so that when we do get into the hospital room or in the home birth, we're all very familiar and aware of what may occur to help labor go a little bit more smoothly.
And then lastly, I think this last question, what coping techniques do you find most helpful during a birth?
Oh, that's a great question. Senses, playing with your senses. So having a birthing playlist. I always keep one on Spotify with relaxing music, I do bring like LED candles. So if I have a mom who is really in an intense labor, I might close the blinds, put the candles on with the music, and then also using lavender, echinacea, and doing massage techniques, depending on where her labor is. Most women that I have experienced labor with have pain mostly in their lower back. So definitely, giving those rubbing techniques, changing her positions, giving light and firm touch, getting dad involved in those things. So I might be rubbing the back and dad might be rubbing her shoulders at the same time and getting her a cold cloth.
Okay, another question, Jessica. Have you faced any challenges with hospital nurses during a labor?
Oh yeah. Oh yeah. We have a joke. I go to Yale Ward and I have to warn my clients that sometimes you're going to get a really great reaction when they see me. And sometimes it may not be, as joyous when I come into the room. I would not really say the nurses so much, except for, the obstetrician or the general practitioner. That's where sometimes my challenge comes in. But nurses are usually very pleasant to deal with, and support doula work. And I have found oftentimes have experience as a doula before they became nurses. So the challenges are there. But I find that approaching them appropriately and listening to the other person's concern, just like we would with any relationship, the communication style definitely helps to alleviate any additional tension in the room.
With that communication style, Jessica, I can't type sometimes as fast as the question comes to me. If issues of a personality conflict occur with a client, how do you manage that and recover from that so that your services can continue? Because I'm sure that must come up quite a bit with women who are just stressed with the pregnancy.
Absolutely. Absolutely. One good way that I use is just like not to take anything personal. Nothing is personally an attack on me. And always being a listening ear, never cutting someone off or jumping in to answer a question before they finish, and making sure that their voice is feeling heard, and that my answer is equally supportive, even if it's not something that I personally would do, giving moms and dads the option to say, hey, this is what we want to do. And that's not personally what I want to do, but always making sure that my support doesn't come from a personal place, but a professional place.
Another question, religion can be a touchy subject with some clients. Do you incorporate your spiritual beliefs in your services, and how so?
I don't, because I've had a bevy of clients who come from, that are Muslim, Buddhist, Christian, some who are atheists. So I don't practice religion in my services. However, if there is something that someone may have a question on regarding their religion, I'm happy to study on how to best support them. And if their character and their integrity kind of just doesn't align with something that makes me feel comfortable, I always have the option to say, you know what, let me refer you to someone else who can better serve you. And I have done that for people who I just honestly, I'm not able to give them the level of care that they desire.
Another question is what happens if you have two clients in labor at the same time? Do you have a backup doula?
I do have a backup doula currently. So that's really helpful, even if someone's not in labor. Let's say I have someone who is really not feeling well and I have to rush to the hospital with a client who's not even close to labor. Having a backup doula is really, really helpful. And I usually introduce her to clients during our prenatal period, just so that they see the face But I do make every effort to be there for my clients, and I do not double book. So if you're due on October 3rd, I will not take another client during that time frame. And I limit that to 2 clients a month to alleviate that. So I haven't had to use her at all in the past, but as referrals start to come in a little bit more, I definitely could see her stepping in, even to give me a break for labor times. Sometimes you're in labor for 27 hours. And so I may need to break, go home, eat, change, and she'll step in for a few hours so I can get some rest, and then we'll swap off.
So your backup doula, I'm just sort of thinking as you're saying that. So your backup doula often accompanies you to your clients so that they're comfortable with both of you in that event that might happen?
Yes, not often, but we do one visit prenatally where she'll come in, she'll go over birth plan with them, make sure that it's a good connection for them as well. I would hate for any of my clients to be uncomfortable with my backup doula in the event that I do have to use her. But yes, they do. I do make sure that they do connect with her at some point before they go into labor.
Another question is, why did you decide to become a doula?
Ooh, I like that question. I had a very, very traumatic first pregnancy when I was younger. And I remember feeling very detached to my son when I had him, feeling very unsupported, suffering from extreme bouts of postpartum depression, so much so that, I couldn't even nurse. I laid in bed all day. I barely ate, and feeling alone, feeling very, very alone. So I joined some mom groups by suggestion of a friend. And I found that my story is one of so many stories that women of color, especially, can resonate and relate to. So I met a doula, and she became an awesome mentor in my life. I never thought that I would ever become a doula. I just kind of thought that wasn't really my career path. That wasn't something that I cared about so much. But the more I became an advocate of mothers, and the more that I had friends that would say, Jessica, can you give me tips on what to do when I'm in labor? Or I really like your parenting style. Can you help me with breastfeeding? Someone said to me, you should become a doula. And it took me 2 years to really say that was something I wanted to do. But I'm so happy I did, because I really, really feel like this is so needed, even in just the New Haven area. To be able to support mothers of color, undocumented mothers, LGBTQ mothers. These services are just not there for them. And you know you're calling when you're doing it. I know it sounds kind of cheesy, but when you're doing the work, even though it's long and it might be tiring, I always feel like something good happened.
And lastly, what can we do to push legislation for doulas?
Oh, that's an awesome question. I actually have a number that I can share in the chat. Call Ned Lamont's office and ask him to pass CTSB1. I'll be happy to share that information in the chat. We are so fortunate that it even got to him at this point. It's been a 2-year, almost 3-year actually, from start to finish process. So one step closer to being able to get doulas to get Medicaid reimbursement, to serve way more mothers, and to be able to get more people certified as doulas as well.
Wonderful. Yes, please share that in the chat as we segue to our final panelist, Dr. Danielle Holmes. Thank you so much for everything, Jessica. That was illuminating. So I'm excited to share our next panelist, who is Dr. Danielle Holmes. She's an obstetrician and a gynecologist. Dr. Danielle Holmes is a champion and advocate for women's health. So sorry, I just wanted to make sure I unmuted. Dr. Danielle Holmes is a champion and advocate for women's health. Dr. Danielle Holmes is also known as Dr. Danielle, and she's a board certified obstetrician and gynecologist. She has navigated through her years of school and her medical training with top honors and awards. Dr. Danielle, a sought-after OBGYN in the greater Washington, D.C. metropolitan area, has years of experience in gynecological care and obstetric care. Due to her experience, she has also been sought out as a medical legal expert. She's enjoyed teaching private and military residents surgical skills and has been awarded for her efforts. Having delivered thousands of babies, caring for their expecting mothers, and caring for women in all stages of life, Dr. Danielle is a compassionate leader in her field. Dr. Danielle is extremely active and has been on the executive board of her local medical society and served on local hospital committees. Her compassionate care has also been displayed internationally as she has conducted nutritional research in villages in Tanzania and conducted medical and surgical missions in Nigeria. But most importantly, Dr. Danielle connects with her patients on a personal level so that they are comfortable as they receive exceptional medical care. Dr. Danielle founded Holmes Health PLLC in 2019, in which she provides exceptional medical care to communities in need. Dr. Danielle is author of an upcoming book that helps expecting mothers navigate through their pregnancy journey. She truly believes in the motto, healthy mother, healthy baby. Dr. Danielle graduated magna cum laude from Xavier University in Louisiana with a degree in chemistry. She then earned her doctorate of medicine degree and completed her obstetrics and gynecology residency from the University of Connecticut School of Medicine, where she has received numerous awards and honors. She has been practicing in the Washington, D.C. area for the past 13 years, where she lives with her loving husband, Jermaine Heath, and her beautiful 20-month-old daughter, Layla Ann. Dr. Danielle is a proud Diamond Life member of Delta Sigma Theta Sorority Incorporated and current member of the Federal City Alumni Chapter in Washington, D.C. She is also a proud legacy of Lillian Holmes and a proud big sister to her biological big sister, Jennifer Holmes, two of my favorite sorors. I am very excited to introduce Dr. Danielle to you, for her to bring forth her information. She's going to take us on a journey through decades as women, as we're navigating our healthcare journey. And I'm going to turn it right over to her so that she can get started on this valuable information. Dr. Danielle.
Great, thank you, Sora Yvette, for that wonderful introduction. And I want to thank the chapter just for inviting me to be a part of this wonderful health symposium. So thank you all very much. So I was asked to speak about, women's health, and that is such a huge topic in general. So I decided just to break up my discussion pretty much in terms of decades of life as we are on our health care journey, throughout life. So because women's health is very individualized and you have different needs at different stages of life, I thought I would basically divide this talk again into different decades of life, 20s, 30s, 40s, 50s, 60s, 70s, 80s, and beyond. And again, just remembering one decade can definitely influence the next decade. So the discussions that we're having today, we use this base information from one point in life, and that will help us move forward to the next stage of life. Next slide. So in terms of health maintenance, and especially when we start off, in our young lives in our 20s, young ladies definitely need to establish, care with primary care physicians who can really assess their overall risks. And there are certain things that we have lifestyle, changes that can contribute to your overall risk, over the course of your lifetime. And specifically cardiovascular risk is a very big topic because heart disease is really the #1 reason for death in America. So if you can start very good habits in the very beginning, in the start of your life, you will definitely be better suited for down the road. So really, primary care physicians try to assess cardiovascular risk factors about every 3 to 5 years in the decades of the 20s. And there are so many risk factors that can be modified that can actually help have a better cardiovascular outcome in life. And so that includes having a well-balanced diet, continue to exercise on a daily basis for at least 20 to 30 minutes. Obesity is obviously an epidemic in America. And so, diet, exercise obviously contributes to obesity if you are, not doing the proper exercise, or if you do not have the best diet, that will contribute to obesity, as well as smoking that will wreak havoc on pretty much every organ system in your body. So these are definitely risk factors that can be modified. And when you talk to a primary care physician, they can help guide you to decrease your risk for cardiovascular issues for down the road by modifying these factors. Next slide. So in terms of the gynecologic issues surrounding women's health, we start Pap smears at the age of 21, and Pap smears are, it's a test to look for cervical cancer. Guidelines have changed over the years, and women are kind of accustomed to getting Pap smears every year because that's what we have always done. But guidelines actually changed, some years back, that we know that we don't necessarily need a Pap smear every year, but we do start at the age of 21, regardless of the start of sexual activity. And it's very important just to have that part of preventative care, because if there is an abnormality over time, there is actually things that we can do to prevent the development of cervical cancer. And again, individualizing care, with your provider is always important. So that's why it is very important to have that primary care physician. Common concerns, again, for women in their 20s, if they become sexually active, they may not be ready for a baby. So you talk about contraception. There's so many different options for contraception these days. There we have IUDs, intrauterine devices, old school birth control pills. We have vaginal rings. We have arm implants. We have patches, condoms. There's so many different, modalities, and we really like to tailor it to a person so it would be best suited for them. And in that regard, sexually transmitted infection prevention is very important, and testing for women who are more frequently sexually active. That is very important because sexually transmitted infections can obviously have a very dramatic impact on health over your lifetime. So we do talk about prevention, during these visits. HPV, or human papillomavirus. So that is the virus that can cause abnormalities with Pap smears as well as other genital lesions. And we do have a vaccine that is available. And actually, with the start of this vaccine, we have significantly decreased the rate of cervical cancer and just cervical dysplasia, or what we call precancer cells. So it is definitely recommended for women to get vaccinated. And actually, you can start in your pediatric age population. So a lot of pediatricians will start vaccination starting even at the age of 9. But it actually is FDA approved all the way up to age 45. It is best to get the vaccine prior to any start of sexual activity. The next thing to really, focus in on is domestic violence screening, especially for women who may be in relationships in their 20s. We try to actually address that almost at every visit that you come in contact with, a primary care physician or a gynecologist or just your main doctor. Obviously, that is something that can significantly influence health, mental health, and contribute to even life and death situations. So that is one thing that we do not forget about. And also in that regard, issues with anxiety and depression, that is very important these days, considering the climate of what is going on in the world. There are so many issues with people feeling isolated, leading to lots of anxiety and depression. So it is important to screen for that even in the very beginning of someone's life in their 20s, because there are definitely lots of interventions that can be utilized to have a more productive life. Next slide. So generally common concerns with people in this age group, they really want to know what is the best birth control for them, and are they at risk for sexually transmitted infections, and if they do have them. So as I said before, if you can see through this picture, there is a whole host of different options. So these are the things that really, it's nice to have that relationship with a primary doctor so that you can tailor what would be best, for that individual patient. Next slide. So really, just to kind of summarize for the 20s, it really is really important to establish that primary care physician early on in your 20s. You want to establish good habits in the very beginning, so that will help you navigate your journey, over your years. And a lot of young people don't necessarily think about that. They come when there's only specifically, a problem. And one thing that I put on the slide, I was like, don't go to the emergency room for routine care. So I found that a lot of, young ladies in their 20s, because they do not have a primary care physician, if there's something that's minor that's bothering them, they actually go to the emergency room. And the emergency room is wonderful for emergencies, but it is not wonderful for routine care. And the reason why I put that on there is because when people do go, I think they have a false assurance that they have gotten appropriate care when they go for routine things to the emergency room, but that really is not the case. So you really want to establish a relationship with someone long-term. And people who do have primary care physicians do have higher rates of, preventative services that will help them in their healthcare journey over time. The other thing is just really, even at that young age, know how your insurance works. A lot of times people will say, I'm not going to go to the doctor because I don't want to have to pay for this. But those preventative visits, according to the Affordable Care Act, those are actually covered. So there may not be a lot of out-of-pocket costs for patients. So if you just kind of know where your insurance lies from the very beginning, that can help you navigate, down the road. Next slide. So now we're going into our 30s. And pap smear issues kind of change a little bit at the age of 30. Under 30, we generally do not check for HPV. And the reason for that is because women in their 20s are more likely to, even if they do have HPV, clear it on their own. And it is unlikely that they actually do have cervical cancer when you're under 30. But once you get to age 30, if you do have HPV or human papillomavirus, it is a little bit more likely that it actually sticks around a little bit longer. Your immune system is not as robust, so sometimes your body cannot clear it over time. So we start doing routine HPV tests at the age of 30 in addition to pap smears. The screening guidelines, if it is normal, if you have a normal pap and a normal HPV test, we can actually do that every 3 years. And the reason for that is HPV is a slow, if somebody has HPV, it's a slow growing issue leading to cervical changes and potentially cancer. So if you have it normal, you can actually do your next pap smear at 3 years. Now, having said that, people have translated to that, I don't need to necessarily see the doctor on a yearly basis. That is not also true. We still see people back on an annual basis, but you don't actually have to run the pap test. We talk about self-breast exams. Breast health is very important, especially for African-American women. We know that we are at higher, rates of breast cancer. So we talk about, continuing self-breast exams on a monthly or even, bi-monthly schedule. We talk about, conception counseling. So now that we're in our 30s, we've gone through different stages of life, you may be ready to have a baby. So we talk about what are some of the factors that can contribute to, healthy pregnancies, and what things that you can do beforehand to help you have a healthier pregnancy. And then some people really have that desire to have a baby, but they may not be in a social situation that they can have a baby. And even though their desire is strong, it doesn't necessarily look like they would have one sooner than later. So I always encourage people to consider egg freezing. And that's one thing that people don't always, really talk about. And there is a medical term called advanced maternal age, and that is when women are 35, the age of 35 at the time of their birth. And that just increases some of the risk in terms of genetic issues with babies, and other things, other complications can arise. So if you can have your babies before the age of 35, that would be fabulous. But again, that is not always the case for everyone. So there are specialists called reproductive endocrinology and infertility specialists who actually can start the process to help freeze your eggs, so that down the road, if you are in a better social situation where you would want to have a baby, but you're potentially a little bit older, say if you're thinking about this and you're 32, you're not in this situation, but then by 39, you might be ready, you could have frozen your 32-year-old egg, gone through some IVF procedures, and then have that implanted back into your uterus. So at the age of 39, you could have the egg of a 32-year-old, and outcomes are definitely better in that regard. It is a little bit pricey. It's generally not covered by insurance. So that is the downside for it. But for people who are very adamant that they do want to have a family, I definitely encourage them to do that. On average, one cycle to freeze eggs usually is about $7,000 to about $10,000. And then again, if we are, we go and then we become pregnant, we talk about obviously prenatal care. And Ms. Westbrook, went over some of the care that she provides as a doula. And obviously as obstetricians, we provide the scope of prenatal care from the very beginning of pregnancy, all throughout birth and postpartum. Next slide. And so there's common concerns that come up for women in their 30s. We have the nemesis of the African-American woman, which are fibroids. And it seems just like it's kind of an epidemic for fibroids. And fibroids are benign growths that can happen anywhere within the uterus. And it can contribute to a lot of issues in terms of heavy bleeding, pain, problems with infertility, and actually can cause some issues within pregnancy. So those are common concerns that our patients end up, discussing with us, and how it's going to impact if they can have a baby or will they have a baby. And again, they have concerns about how their prenatal care, will be considering the climate of what is going on in terms of maternal mortality. And Ms. Westbrook had mentioned a little bit about that, and I'll go with a couple of slides myself. Next slide about that. Prenatal care. So I cannot reiterate about how important prenatal care is from the very beginning of the time that you find out that you're pregnant. Providers, whether it's an obstetrician, whether it's a family doctor, whether it's a midwife, and support doulas, it is very important to establish care in the very beginning, because that will kind of help dictate how the rest of your pregnancy will be. Where I am right now, I actually have a lot of patients who, for lots of reasons, do not present for prenatal care early on in pregnancy. They present in the third trimester, or literally in the last week of pregnancy, and outcomes for mom, outcomes for babies are not very good. So we want to establish that care very early on. And you want to have that relationship with your provider, because this is such a special experience, and there are risk factors, for, the mom, for the baby. So you really want to establish that care so that that somebody is really, behind you and rooting for you and advocating for your best health. Next slide. And then it's always, again, postpartum care after you have the baby, that's not it. And in terms of medical issues, there are many issues that can arise after the baby, whether it's preeclampsia issues, whether it's potentially you have a blood clot potentially in your lung, stroke issues, postpartum depression. So postpartum care really lasts like a whole year after you've had the baby. So as obstetricians, we provide that care throughout the course of the time after the baby. We do not forget about moms after they have the baby. And sometimes moms forget about themselves. And so we recommend that they have frequent follow-ups even after their babies are born. Next slide. And so this is basically maternal mortality in 2009. This is from the CDC. And this is from the Morbidity and Mortality Weekly Report, which was published in 2019. 700 women die every year in the US as a result of pregnancy and its complications. And there are so many factors that are involved in that. And that is just a talk in of itself. So I won't go totally in depth, but this is a very important slide. And I like visuals of this. And I don't want to bore people with numbers and statistics as much, but the next two slides, I think specifically for African-American women, are very important. So this, again, is related to data from 2007 to 2016, okay? And it is looking at pregnancy-related deaths per 100 live births. And if you look at this, white women, their number is 13, Native American, 30, and for our African-American women, it is 41. Next slide. So next slide is basically the same thing, but it just kind of gives you a different representation. The bottom line is all women. For maternal mortality in 2019, again, from data from 2007, 2016. So all women, that is about 13 deaths per 100 live births. That's all women. And then, 16.7 for all women. And for white women, it's 13. For Native American and Alaskan Native, it is 29.7. And for our African-American women, it is 41%. And if you can just look at that, it is a dramatic increase. And there are so many different factors, whether it is access to care, socioeconomic status, other morbidities, racism. There are so many things. And this is actually a very hot topic in obstetrics right now. And lots of different societies are really looking into what is really contributing to it, because it is just not one factor. And we have to make these numbers better because our lives depend on it and our families depend on it. And so again, this I think just gives you a visualization of why we need to have better legislation for healthcare and having access to care for one thing. But again, this is something that has to change. Okay, next slide. And again, so for tips, in the 30s, I really want our patients to really do their research, look for qualified healthcare professionals. And everybody doesn't have the same level of care. There are some people who are low risk. There are some people who have high risk. If you have high blood pressure, diabetes, if you've had blood clots in the past, if you're on the older side, you generally are considered high risk, and you need to have a healthcare provider that matches that risk. And outside of that, in terms of where you deliver really matters too. Outcomes are determined also based off of the location where you are, especially in terms of African-American women delivering premature babies. You want to have access to a neonatal ICU, and not all hospitals actually have that. So not only do you need to look into your doctor, you need to look into the hospitals and the facilities where you are going to deliver. It is important to ask questions, get second opinions, third opinions, fourth opinions, because ultimately it's your life at stake. And so it is never an issue to question your healthcare providers. It actually, I think, has better outcomes, overall. All right, so next slide. So now we're moving into our 40s. So now we're at the big 4-0, and this is when we start getting mammograms. And yearly mammograms, especially 3D mammograms, are recommended starting at the age of 40. There's different schools of thoughts of really when to start, and there's some societies to start a little bit later, but in terms of what gynecologists recommend, and most people, we do recommend starting at 40, and most will do a mammogram every 1 to 2 years. And that is something that you can individualize. But 3D mammograms make a big difference in terms of the traditional 2D. It makes the picture so much clearer, and a lot of things that can come up on a mammogram versus a traditional mammogram versus a 3D, you can actually see minor changes so much clearer with a 3D mammogram. So 3D mammograms are usually mostly the mainstay these days. Now, again, in the 40s, we may have had a couple babies before, and you may not necessarily want to have any more babies. So we do talk about pregnancy prevention. And actually, sometimes women's cycles start to get a little irregular as we go into perimenopause. So they think that they can't get pregnant. But actually, women in their 40s, they do actually have a higher risk of unintended pregnancies because they think they cannot get pregnant. So the average age of menopause is 51. So we still talk about pregnancy prevention, you know, in those years. And again, as we do get closer and closer to menopause, you may be in perimenopause, which happens before. Perimenopause happens 5 to 8 years before you actually go into menopause. And that's when hormones start to become a little inconsistent. And so you can have inconsistent symptoms of irregular periods, mood changes, hot flashes. And so those are issues that can definitely be addressed, you know, with your, you know, gynecologist. There are a lot of medications and lifestyle interventions that we can do to help minimize some of the symptoms. Colonoscopy, that is a big change. In the last couple of years, the recommendations for colonoscopies have changed. For years, it's been recommended to start at the age of 50. And more recently, the guidelines have changed to start to age 45. And actually, for African Americans, it has been 45 for a while because we are at increased risk of colorectal issues. But the reason for this change is because we have been seeing invasive cancers in younger populations. And colorectal cancer is a very big issue, you know, within the US, whether it's related to diet, exercise. So again, recommendation is definitely at 45. If things are normal, it's usually recommended to do follow-ups every 10 years. If they do see some potential changes, sometimes the follow-ups are every 1, 3, or 5 years, depending on what's going on. Next slide. So again, common concerns that happen in the 40s. Again, we talked about breast cancer. I mean, I think, you know, women's, they're heightened to the possibility of breast cancer. So again, we advocate, you know, self-breast exams. We advocate, you know, mammograms. And for some people who do have a quality of what we call dense breast, where you just have denser tissue, sometimes additional ultrasounds are recommended for screening because it just gives a little extra layer of surveillance. Again, common concern, especially in the African American communities, you know, you may have now been diagnosed with fibroids. And as you can see in this picture, they are just growths that can happen randomly anywhere in the uterus. And we describe them based off of their size and their location. And one can have a small fibroid and have multiple symptoms because of their location, where somebody could have ones of different size that it may not be much of an issue. But again, there are things that we can do to minimize symptoms, and we'll talk about that in the next slide. But fibroids can obviously contribute to if you want to still conceive, and that sometimes involves surgery. And again, for women in their 40s, if they still want to have children, we are concerned about timing of that, because some of the treatment modalities, you do have to wait, you know, prior to pregnancy. Next slide. So specifically for fibroids, there's medical treatment, there's surgical treatment for fibroids. And again, nobody really knows why we have fibroids. There's theories of diet, exercise, increased estrogen, you know, causing some of this, but to be quite honest, nobody really knows. But we do know that African American women are just more prone to getting them. And when we do have them compared to our other counterparts, they seem to be more severe in terms of symptoms. So in terms of medical, these are general treatment. And again, everybody's going to be very individualized, but some people may just have heavy periods, no pain. Sometimes being on birth control can help with the flow. Sometimes people have no issues with bleeding, but they cause pain, and then we can treat it with pain medication. There's also other medication that can decrease specifically the amount of flow of, decrease the amount of bleeding caused by fibroids. There's a medication called Placenta, which is not a birth control. It is not a hormone. It's basically a medication that puts a little wrench in the normal cascade of what happens when bleeding occurs. And so that is a medication that a lot of actually my patients use, and they just take it when they are on their period to help decrease the flow. There's another procedure. I put it under medical because it's not really surgical, but there's a procedure called uterine artery embolization, which for people who don't necessarily want to be on medication, don't want to have major surgery, uterine artery embolization is a wonderful modality, which is done, it's a procedure done by radiologists. And basically they can actually find the specific blood vessels that are feeding the fibroids. And they put these small little pellets, for lack of a better word, these small little devices like in the blood vessel to stop the blood flow. So in theory, the fibroid will no longer have its blood supply and it dramatically shrinks and can help with symptoms. So for people who have other major symptoms, may want to have a baby or just have a lot of symptoms with pain and bleeding, we also have surgical options. Myomectomy is removal of the fibroids. The uterus is retained, so you still have the potential ability to have a baby. That is what is recommended for when women have large fibroids and they do want to conceive. For people who may have finished childbearing or do not want to have children, hysterectomy is the removal of the uterus so that you don't have the symptoms in general. And hysterectomy is, these days, actually, it's obviously a very common procedure that we do specifically for fibroids, but there's different ways to do that. So recovery is actually very quicker in terms of what it had been in years past, basically. We can do hysterectomies laparoscopically with small incisions, so where people generally sometimes can go home the same day and their recovery is usually a lot better, even by 2 weeks. Okay, next slide. So again, now for in the 40s, we may have developed a couple of, medical issues as we are aging. And I always tell people, listen to your body. You know what's going on in your body. Patients know when something is wrong. We just have to listen. And again, it's always important to follow up with that healthcare provider sooner than later. Do not let things fester, because there are so many things as healthcare providers that we can intervene on before it becomes more of an issue. And a lot of times I've seen for my patients in their 40s, we would like to be maybe in our 20s and our 30s, and we think we have the 20 and 30s bodies, but sometimes medical issues do arise. And I think that there is sometimes a lack of acceptance of things that are happening, and sometimes people try to ignore them. But definitely do not do that, because early intervention for most of these issues is the best. Okay, next slide. All right, so now we're going into our 50s. So now we're at that menopausal age, and hot flashes, vaginal dryness, irregular bleeding. These are all things that can happen as we are in that menopausal age. And menopause is a full 1 year of no periods, and the average age of that in the US is 51. Again, talking to your healthcare provider, there are so many things that we can do to help minimize the symptoms. And sometimes people really have mild symptoms, during their menopausal years. And if that's the case, we just, continue on. Everybody does not need medication while they're in menopause, but for some people, it significantly influences their, even their daily life. And there are medications, not necessarily hormones, but there are other medications, even like low dose antidepressants can specifically be helpful for hot flashes. It's not treating depression, but we know through medical studies that low doses, not in the same doses to treat depression, but low doses of even antidepressants can really help with hot flashes. Vaginal dryness is also a very major issue during this time frame, and that can contribute to issues with sexual health and intercourse. Sometimes people have more, pain with intercourse because of their dryness, and that can influence relationship status. There are, again, so many different things that we can do to help with that. So again, it's important to follow up with your doctor to address those issues. Cardiovascular health, again, is very important during this time. Again, as we are aging, we may have had a couple of medical issues. We do want to maintain cardiovascular health, maintain that healthy diet, exercise. Depending on risk factors, a lot of people will get, routine EKGs and checking for cholesterol, and potentially start on some medication if there were some issues with that. Again, it's very important just to maintain, whatever issue is at hand, so that we can have, longevity down the road. Next slide. So again, talk about, what the common patient concerns are for women in the 50s. The hot flashes are really a big issue. The other thing I said is, did I just pee on myself? So that is a very major issue that people don't really talk about. Incontinence. Incontinence is a very common issue that can arise as we get older, and especially when we become menopausal, because you have less estrogen around in your system, that contributes to issues with urinary incontinence. And again, there are so many things that we can do to help with that, whether it's medication, also surgery. So these are things that you should not just generally just accept as, oh, I'm just getting older, this is just what happens. It may be common, but it may not be normal, right? So again, we can definitely intervene when those things happen. And again, we talked a little bit about painful sex, and a lot of times that is contributed to or as a result of the vaginal dryness that happens. And again, medications through even estrogen creams, which is not necessarily considered hormone replacement therapy, but that can actually be helpful as also as personal lubricants. And again, that's really important because sexual health is really important. Studies have shown that, people who are more sexually active, it influences other things. It actually increases your, cardiovascular health. It increases your overall sense of well-being. And actually, there's been some studies that showed that it can, increase your life expectancy, actually. So there are definitely benefits for intercourse. And so it doesn't necessarily have to end. And so we definitely want to address that in our 50s and even beyond. Okay, next slide. All right, so again, for tips for 50s, again, just do not accept, conditions just because you think like this is what happens as I age. There are so many medications, procedures, changes, life changes that we can do and encourage people to do. So again, it's important to be proactive in all of that. Again, we should have been exercising, in our 20s, 30s, and 40s, but if you haven't, we want to make sure that you continue or just start to exercise because your hormones have changed, metabolism has changed. People start to increase their weight, even when you see that you haven't changed much else in your life. So again, it is really important to exercise to maintain that. The other thing is to maintain mental sharpness. You want to obviously, there are issues with memory issues, for down the road as we age. So this is the point where you really want to maintain that sharpness, learn a new language, do things that you don't like puzzles or crossword puzzles. You definitely want to continue making, continue doing things to keep your mind sharp. Next slide. All right, so now we're going on to from our 50s to our 60s, 70s, and 80s. The other issue with menopause is bone health. We do generally start DEXA scans, which are considered bone scans, usually at the age of 65. They can happen earlier if people do have other risk factors in terms of certain medications can put you at risk for decreased bone strength. One thing though is for African-American women, we tend to have a little bit more of a denser bone. So we generally have less issues with things like osteoporosis or osteopenia, but it can still definitely happen. Women who have a smaller frame or a low BMI or low body mass index are definitely increased risk. So as you age, you need increased calcium to maintain your bone health. You generally need about 1,500 milligrams of calcium per day, when you're menopausal, and that will help maintain bone. In general, for our other years, your estrogen helps maintain bones. But so now that you don't have as much estrogen around, that's when the decreased bone mass can happen. So it is important to have these screening tests, the bone scans, and to continue calcium. Weight-bearing exercise is actually very helpful to maintain bone strength. One thing that, sometimes my older patients get a little alarmed about is that we stop pap smears. They're used to seeing us every year and then I need to get my pap smear, but there is generally an end to pap smears. We do not do pap smears indefinitely. So for women who have had normal pap smears, they have not had HPV, they have not had any cervical dysplasia, you can actually stop at the age of 65. Again, there are some caveats to that where we do continue on if some people are at higher risk, or if they've had, HIV, it puts them at risk for cervical issues. So we may continue on, but don't be alarmed if your doctor does tell you we don't need to do a pap smear anymore, because yes, at 65, if you've had normal all of your life, you can definitely stop at 65. And again, we talked about the vaginal dryness and the painful intercourse before, so I will not go into that a little bit more in depth now. Okay, next slide. And again, so these are the common concerns. All of my patients who are in this age range, they are somewhat shocked that we say that we don't necessarily need a pap smear anymore. But again, if there had not been any changes in your cervix by the time that you were 60, I can pretty much bet there would not be any more changes, for the years to come. So yes, we can stop at 65. Then the other common concern that happens, for a lot of women in the 60s, 70s, and 80s, it's like, what's that hanging out? All right, so next slide. So when we've gone through menopause, we have decreased estrogen. You may have had a couple of babies before, whether it's vaginal deliveries or C-sections. There's something called pelvic organ prolapse, all right? So the pelvic floor, there's lots of muscles in your pelvic floor that help support your bladder, your uterus, your rectum. So you can see in this first picture, this is the normal anatomy. And do I have control of this? No. So this first picture, that is the normal anatomy. If you take a woman in half, you cut her in half like this, and then you look on the side, this is what the normal anatomy is. So you can see the uterus is high in the pelvis, the vagina is long in length, and then there are some muscles that are yellow that are holding up the bladder, and there's some couple small muscles that are keeping the rectum at bay. So when we lose our estrogen, when we've lost some support because of deliveries, what can happen is your bladder can push a little bit into the vaginal canal. So the actual bladder is not in the vagina, but that it's because the bladder has, or the muscles have lost its tone, it's actually pushing into it. And so you can actually feel a bulge there. That can also contribute to some of the issues of urinary incontinence that we were talking about too. On the opposite side, the same thing can happen for the back side. So sometimes the rectum can push a little bit into the vagina, and that also causes the bulge. These women generally have a lot of issues sometimes with constipation, or they feel that they cannot completely evacuate. And sometimes they actually have to put their hand in their vagina. If you can see, put their hand in the vagina and then push to have the stool come out, okay? Now the next one is uterine prolapse. Again, so that is when pretty much all of the support of the pelvic floor is lost. And actually your vagina, your uterus can come to the level of your vagina and potentially even hang out. And that's called a prolapsed uterus. And the last one, that's vaginal vault prolapse. So those are for people who've had hysterectomies before. So you don't have the uterus anymore because you've had surgery. But the support of all those muscles is completely lost. And so again, that is the vaginal wall that is coming out, okay? And so these are lots of concerns that can happen for women in their, the older years. And again, there are things that we can do, surgical things that we can do. And there's also devices that we can use. There's something called a pessary, which is a little device. It looks like a diaphragm, if you've ever used diaphragms, years back for contraception, or imagine like a little trampoline, basically. So it's a circular device, and we literally put it inside the vagina. You get actually fitted, by a gynecologist, and it literally can hold up the pelvic floor so that you can avoid some of the symptoms. So a lot of people have pelvic pressure, again, urinary incontinence, sometimes issue with the bowel movement, and just sometimes just pain and irritation because of all of the pressure that arises. And there is actually a subspecialty within gynecology. It's called urogynecology, specifically to all of these issues of prolapse. And they are actually specialists that can actually help give you extra support surgically to rectify all of these issues. Okay, next slide. All right, so again, so for tips in our older years, it is still important to seek that medical care for prevention and, treat problems. We want you to take care of or take control of your medical care. Know your medications, know your dose, keep a list of your medications in your purse. Know what your medical issues are. You'd be surprised about how many people don't even really understand their medical issues. And the other thing is really staying positive. People who have a positive outlook on aging, I think, do a little bit better. And there's been some studies that show that it actually can increase your life expectancy. Again, it's important to maintain relationships and to stay active. Maintain, relationships with friends and family. And again, you just have that positive outlook on life. It gives you a better general sense of life, and it helps with your long-term outcome. Next slide. All right, so just in general, I hope I gave you a couple little tips about how we can be empowered to take care of ourselves throughout the years. Next slide. And again, whether it's through diet and exercise, we want to make sure that we take control of our medical care. And next slide. And again, maintain healthy relationships with each other. Make sure that you put yourself first. Next slide. And if you continue to do all of these things, we can get to the and beyond, like this 99-year-old great-great-grandmother who is doing CrossFit and who is running in a 100-meter race. So if we do all of these things for our health, we can get to this level of the and beyond as this 99-year-old woman has done. Next slide. All right, and again, thank you very much, for your time and attention. Again, just hope I gave you a little bit of information about how we can journey through health, and so that we can have healthy, happy families throughout all the generations. Next slide. Thank you.
Wow, Dr. Danielle, thank you so much. I think I'm clapping for everybody who can't unmute, because I am just, I'm amazed. There are so many questions in the chat, so I want to have time for you to get to those. I hope we can get to all of them.
Okay.
Some of them you answered in your presentation, so forgive me if there's a repeat. Maybe you just gloss over that for the person.
Okay.
But I know it's some of them I noticed as they were coming in. My private chat and tech phone were going off. All right, first one. Uterine fibroids are very common for African-American women. Is there a reason for that?
Yeah, that's the thing. We don't really know. So we don't really know what really causes them. So we don't know why, unfortunately. Throughout all of our research, we can't really find the inciting factor for it, but we do know that it just affects us more. But unfortunately, we don't necessarily know why that is the case.
Okay. Missed and heavy periods during perimenopause. When should I worry?
Well, so if you're perimenopausal, it is actually normal to have some missed periods. So that's actually okay. So in terms of heaviness, if it gets to the point where you are having signs of anemia or like a low blood count, or if you considered like what we consider kind of a hemorrhage, is when you completely soak like a tampon or a pad within an hour and it's just not stopping. That's when you really need to seek care. And actually at that point, you would really need to go to the emergency room. It can get to that point where it's really that heavy, but for missed periods, that's actually okay if you're definitely in that perimenopausal age. But in terms of the heaviness, we wanna make sure that it doesn't get to the point where you become anemic and become symptomatic, dizzy, faint, pass out. We don't want it to get to that level.
Okay. Has the acronym changed from STD to SDI?
Well, yeah, so we usually say sexually transmitted infection.
Okay.
It's just like semantics in terms of disease. So people still use it interchangeably, but nowadays, I guess the politically correct term is more infection than actually a disease.
Okay, and further, I'm old school, so I've never seen it written this way. Are they still advising young males to take the HPV vaccine series as my son took in middle school?
Yeah, absolutely. So actually, males are the harborers of HPV, to be quite honest. So yes, so it is very important for men or young boys to actually get it, because they may not actually have symptoms of HPV, but when they became sexually active, they potentially could infect their partner, and then they potentially could get an abnormal pap smear. So initially it was for girls, But we know that because men are the harbors, it has changed. And so boys definitely should get vaccinated.
Okay. Do you provide general medical care?
So I'm an obstetrician gynecologist. So I am specifically for OBGYN. I don't consider myself completely like a primary care physician. So that's usually with internal medicine or a family medicine doctor. Now, a lot of women like to go to the OBGYN and kind of treat us as a PCP, but we're really not. And again, because of how medicine is, there's so many different like changes and nuances. And I mean, we are not all up to date on all of the specific changes. So it really is important for a woman to have a gynecologist, but also have like an internal medicine doctor or a family doctor in addition.
Okay. Can you please explain the difference between a domestic violence screening versus anxiety screening, and which may create the same results for domestic violence cases?
So, I mean, so basically in terms of domestic violence, we're trying to figure out if a person feels safe in their environment, if they feel safe in their relationships, okay? In terms of screening for anxiety, yes, they could be potentially interrelated, but they're two separate things. I mean, somebody cannot be in a relationship at all and still have, anxiety and depression. So we talk about loss of interest in things. Do you have difficulty getting up in bed? Do you just generally feel, down and out? Do you have thoughts of hurting yourself? Do you have thoughts of hurting other people? So those are the screenings for anxiety and depression. It's completely separate from domestic violence, screening, although they potentially could, interact with each other too, but they are completely separate.
Okay. Does an early menstrual cycle affect a woman's egg maturation in her 30s?
Generally, no, not the case. So sometimes with that, you may notice that you may go into, you may have menopause maybe a little earlier than that, but it doesn't necessarily change it for down the road when you're in your 30s in terms of, maturation of the eggs.
Okay. Why are urinary tract infections so problematic for women above 50?
Well, partly, so anatomically, the exit for the urethra is very close to the vagina, and it's very close to the rectum, all right? So, and because now when you're in your 50s, you have generally less, lubrication, the tissue gets a little bit drier. So now just the normal bacteria that is usually kind of hanging around in the area can actually have access, to the urethra actually. So sometimes when you treat the vaginal dryness and those issues, sometimes the urinary tract infections, can improve in terms of the frequency.
Okay. Are there conditions that cause early menopause?
Well, there's something called, there's yes, to answer the question, yes, there's some things, specifically premature ovarian failure, and that actually happens very early on. And those are hormonal issues that can happen even in like 20s, 30s, early 40s. So there are some issues. The average age is 51. So if somebody has menopause like around that time, if you're like 48, that's fine. But if somebody's having some issues like in their 30s, that is definitely early. And you would need to get evaluated for that.
Okay. Are there tests to diagnose menopause, and when and how long is perimenopause typically?
Yes. So the diagnosis for menopause is talking to a patient, because you do not need a test for that. It's basically a full 1 year of no periods. So a lot of people come in like, oh, I wanted to get tested for menopause. All you have to do is talk to the patient. Granted, we do tests because people tend to like really want the test, but we don't really need to clinically always do that. There is a test called FSH, or follicle stimulating hormone. And if that test is elevated, that usually is kind of a confirmation of menopause, but you do not necessarily need a blood test to say you're in menopause. Again, if it's a full 1 year of no periods, when we're at that age, that's menopause. Now, the other thing is, you should not have the return of a period. Okay, so once you've had menopause, Some people are like, oh yeah, my period returned. No, that never happens. That is considered postmenopausal bleeding, and that always needs to be evaluated because that could be a sign of uterine cancer. So if you've gone through your 1 year of no periods and you start having bleeding again, always get it checked out.
Okay, great. Thank you. How do women go from normal mammograms to having breasts that become dense when they haven't been previously?
So the density is just actually a characteristic. That in and of itself is not necessarily a problem. And actually the way that they're doing mammograms now, they're different. So you may have had one mammogram to say you've done modality A. Next year it was like it's a different one where you can actually look into density a little bit different, but that's not saying it's actually abnormal. The density is just a characteristic, and that actually makes it a little harder to read a mammogram. So maybe they got a different mammography, scanner or something, and they're just recognizing that, yes, you have dense breasts. And if that's the case, 3D mammogram is best for women who have dense breasts. And again, your doctor may also order an ultrasound for density, but that in itself is not necessarily an abnormality.
Okay. How long is menopause typically?
Oh yeah, sorry. Menopause is, again, average age is 51, and technically it's 1 year, right? And then you become postmenopausal after that. And the other, I think I didn't mention it when somebody asked before, perimenopause is usually 5 to 8 years before somebody's own menopause happens.
Okay. What can women do to address menopause and intimacy issues?
Yeah, so a lot of that goes back to kind of the vaginal dryness issue I was saying. So to be quite honest, there is the whole adage, if you don't use it, you lose it. And it really is true. So you really want to address those things kind of earlier on. There are medications, vaginal gels and creams that are estrogen that can actually give you extra lubrication outside of just normal lubricants with intercourse, basically. And there's also hormonal, medications that can be given. Sometimes there's low desire too. Actually, there are some medications that can help a little bit with that. It's not to the same level as like Viagra and all of that. But when you treat the vaginal dryness issue, usually that gets better. And vaginal health at that point is actually really important, because if you go this long period of time and then you are not actually having intercourse, the vagina actually starts to, or that actually helps maintain the length. So the length can actually shorten over time if you're not regularly sexually active, so that when you do, eventually it becomes super painful. It's harder to do pelvic exams. So there is actually some benefit, even medically, to continue to be sexually active.
Okay. Why is there mood pendulation in perimenopause and menopause?
It's really because, in our 20s and 30s, your hormones were kind of at this steady state. Okay. And now when you're in menopause, they're all over the place. Okay. It's not consistent. So that kind of goes along with the mood changes, because your hormones that are controlling your period are not the same.
What can women do to alleviate symptoms of depression and anxiety during perimenopause and menopause?
Well, one thing is really just that's many things in terms of exercise, diet, counseling, talking to people about it. It's not always just medication. Yes, I can give you a medication, but there are so many other things too. Specifically, that I think counseling is actually very, very helpful too. There's behavior modifications, decreasing, smoking, alcohol intake, but counseling, medication, and just really, continued care can definitely be helpful, over time.
If you've ever had HPV, do you always have it? Does it live in the body, and therefore still needing PAPs in your 60s and beyond? Sort of multi-layered.
So HPV does not always live in your body. You can actually get rid of it. Your immune system can rev up and actually get rid of it over time. If you're older and you've had it, so in order to stop your pap smears at 65, you have to had your last 2 pap smears were normal, including an HPV test. So your last 2 should be normal, and the last one really should be within 2 years. So you can get rid of it on your own. Just because you've had it doesn't mean that you will always have it. But again, it should be really individualized. Everybody's situation is a little bit different. So I would, definitely follow up with your, gynecologist about that.
Okay. Do Kegel exercises, Kegel,
yes.
Kegel exercises help with preventing pelvic and organ prolapse? I don't want this to be my future.
Okay. Yeah. So the Kegel exercises can be helpful for, I would say, for minor symptoms. And the Kegels are basically where you're trying to squeeze your pelvic floor, kind of in the same sense as if you were trying to stop your stream of urine. All right. So if you do that, you can actually help strengthen your floor. I think that actually can really be helpful for minor issues. And they actually do have something called pelvic floor physical therapy. So just like you go to the PT for like your rotator cuff, you can go to a pelvic floor physical therapy provider, and they actually insert probes into the vagina or the rectum, depending on where your issue is, and it stimulates the muscles. So that's kind of the same aspect of a Kegel exercise.
Wow.
Sometimes people's symptoms are so foregone, to be quite honest, the Kegels really don't help. So when I was getting to the end where it's like complete prolapse out, Kegels really are not going to help with that. But if you do Kegels, prior to that, that actually can be helpful to prevent a lot of those issues.
Okay. Then we have some comments that were just saying, great presentation. Thank you for all the great information. Great, Dr. Danielle. Awesome. A friend. Okay. Best lubricants to use?
I wouldn't say that there's a best one. In general, I would say gels, especially for if you're a little on the older side. The gels are a little bit better just because it coats the vagina a little bit more because of the dryness that's already happening, rather than like liquid. But I wouldn't necessarily say that there's like a specific brand or anything like that that's better than the other. But I think gels in general are better than liquids.
Can the vaginal area be tightened after birth?
Yes, there are some procedures that tend to be a little bit more cosmetic, for that. I wouldn't say it's definitely not standard of care by any regard, but there are some more cosmetic things for that. So to be quite honest, most general gynecologists don't do that or, advocate, for that, but you potentially could find some people potentially do that. But again, it's not standard of care.
One of the last questions is, why the weight gain before and during perimenopause and menopause?
I mean, really, it's all to do with the hormones. And again, that's influencing your all those hormones are influencing your metabolism, and your metabolism slows a little bit, during that time. And so, like I said, you can be doing the same thing that you're normally doing, but then all of a sudden, the weight increases just because your metabolism is not the same. Those hormones influence that. So that's why you have to kind of do a little bit more at that point too. So try to exercise a little bit more, try to really watch the diet a little bit more, decrease those calories when you can.
And the weight gain was attributed to pelvic pain in those 50s and going into 60s. Is it the weight gain, or is it have to do with the hormones?
Can you repeat that again? I'm not.
The pelvic pain that is sometimes in perimenopause and menopause, is that more attributed if a person has the extra weight, I'm assuming?
Well, I can say perimenopause is not a time where you generally have pelvic pain.
Okay.
So if you do have pelvic pain, there potentially could be something else going on. But just being perimenopausal does not cause pelvic pain. So again, if it could be something else, so they're going to have to get evaluated.
Okay. Any resources for financial support for the egg freezing process?
Unfortunately, I do not know of any, for that, to be quite honest. And again, that's, I encourage people to go try to find a job at Google and Amazon, because they actually do cover that actually.
Wow.
But yeah, they do. I mean, a lot of those tech companies will do that because they want their workers to work for them and then have their children later. But unfortunately, I don't know of any for egg freezing.
Okay. What are the health risks? Just when I thought we were getting to the end, right? But this is great. What are the health risks for this the egg freezing process for women in their late 20s, early 30s?
What are the health risks, you said?
Yes, for egg freezing.
Okay, so there's really not many health risks, really. They would give you some injectable hormones that will help stimulate your eggs. And then they get to a point where they follow you with ultrasound, blood work, and they figure out when is an ideal time to retrieve the eggs. So you go under, a procedure to retrieve them. There's not been really any indication of like those extra hormones causing issues with cancer, whether it's ovarian cancer or breast cancer. And again, even children born, from frozen eggs or frozen embryos, they have not shown any issues, over the years. So there are some inherent risk of just hormones in general. I mean, increases the risk of potential blood clot. So that's all the kind of the same, even with birth control. But I wouldn't say they're specifically, with the egg freezing. You will be monitored, to make sure that there's, adequate growth over time, but there's really not many major issues.
Okay. So read a study that said Black women get 1.6 hours of exercise, or probably need 1.6 hours of exercise. Is there different exercises that are best for different age groups?
Well, so, I mean, I think that the exercise that's best is something that you're going to do. So, I mean, if you're not going to necessarily do it, it's not that there's one specific that's going to be better for the age group. As you get older, you might have some other issues going on, like you might have a little bit of arthritis and all that as you get a little older. So you want to kind of tail back on some of the exercise. In general terms, I think swimming is wonderful exercise because you don't have all that extra pressure on your joints. So now that it's summer, really going for laps in the pool, and it's just for everybody, I think that can be helpful. So as you do age, because you have some aches and pains, sometimes people say, oh, I'm not going to exercise, I'm not going to go for a walk, I'm not going to get on my bike. But the more that you are, active, I think you have less of those issues generally. But like I said, I think swimming is just a good around exercise overall anyway.
Okay, so many comments about how wonderful the presentation was, Dr. Danielle, and from some of your family in here, Dr. Danielle. Okay. And definitely sorors, just as I'm going down, just wonderful feedback and accolades for just such a wonderful presentation. I think that's the end of our question and answer period. I just want to double check. Okay, yeah, that's a different. Thank you so much, both Jessica, our soror, Dr. Danielle, I have learned so much. I took copious notes, not just for myself, but I have 3 daughters. So I took in all of those different stages. So I took notes for them and my mom. Good. So I'm just elated that there was so much wonderful, invaluable information for all of us. Because we have to take our health seriously, and it's definitely something that oftentimes we put on the back burner until something is dire. Exactly. And we certainly don't want to wait that long. So I'm going to hand it back over to Sora Katrina and our Madam President for final remarks. Thank you so much, everyone.
So thank you so very much, Dr. Danielle and Jessica, for facilitating this just excellent session for us. There's so much informative material that was provided to us that we can take forward as women. Some information, Dr. Danielle, we're going to save from our husbands, because I think if they heard that, they may, get eagerly and overly excited, but thank you for the information that was shared. And thanks for everyone for attending today. We so appreciate your support and following our events. So we have so many ways for you to follow us, and we ask that you do that. But before, I know we're running out of time, before everyone leaves, we have a brief survey that we've put in the chat. It is a link in the chat, very brief. We want to hear your feedback. Our goal is to continue to bring you programs that are going to be beneficial, that are going to add value to your life, and that is going to help us as a community move forward in so many areas that we need to. So if you could just take a quick, brief moment to click on the link in the chat to address the survey. And we know that we had so many people that were on earlier that had to leave. We ask that you take the link and share it because we want to hear feedback. So if you could take just a moment to do that. And while you're doing that, I'll hand over to our wonderful leader, fearless leader, our president, Paula Irving, to do our official closeout. And thank you so much.
Thank you, Katrina, and thank you, Yvette, and thank you, Dr. Danielle and Jessica. This was a great program. I think we all just learned so much. And while it's a lot of information to know, I think we need to just make sure, like Dr. Danielle said, we stay positive and try not to worry. You know, as we kind of go through life, there's going to be a lot of things happening. So thank you again for presenting to us today. Again, this is recorded, so please, if you need to reference back anything, go to our YouTube channel. If you needed to say, okay, well, I'm in my 40s now, let me zip to the 40s decade. You can kind of skip around, but I know that I definitely learned a lot of information. And as I travel through life and this journey through life, we'll say as women, you know, we have a lot to manage. So we have to take care of ourselves first. So thank you again, Jessica and Dr. Danielle. Thank you all for attending. We'll give you back 9 minutes or so to enjoy this lovely Saturday. But again, thank you for attending, and please connect with us on social media and our website. Thank you all. Have a wonderful day.